Hi there, Melanie Myers, IBCLC, International Board Certified Lactation Consultant in private practice, serving Central Pennsylvania and or wherever you are virtually during COVID-19. I wanted to provide this breastfeeding class because so many are not getting an opportunity to take a breastfeeding class. And that's just one more stressor you really don't need. At the bottom of this video, I'm going to link to my handy infographic I made. It's a PDF file with clickable links, and everything I talk about here is going to also be sourced here. So if you miss something, it's okay, because just download this and you're good to go. It has everything you need to know for the first few days of life. This is what I tease as a 5-minute breastfeeding class. It's a little longer than that, but it's literally everything I could possibly jam pack into the shortest amount of time possible. So let's get started. So first, you're a mammal. Mammals make milk and feed their babies. And you come pre-filled with milk. So during your first trimester, you should have noticed breast changes. That's your body making colostrum, and that is colostrum. It starts with a C, okay? If you can't remember how to say it, just bust it out as best you can. They'll know what you mean, okay? So you come pre-filled. Baby arrives, put baby skin to skin. That is bare-chested baby to bare-chested birth parent. This really starts baby's instincts to lead and find the breast. There's a tendency to want to rush this. Let nature take its course. It can take an hour, sometimes 2. And if there's no other underlying health conditions, you have time. If you really feel like you need to do something, I'm going to show you how to hand express. So here's my faux boob. Remember, breasts are glands, not muscles. So you want to be gentle with them. Harder, faster, stronger is not better. Take your hand, and this is where I tease, you really get to know your boobs with breastfeeding, okay? So if you didn't know them before, you're really going to know them now. So you take your hands and you gently massage, and it really just kind of helps loosen everything up, okay? This is also helpful if you start thinking about baby and thinking about all of those things, because hormonally, this is a hormonal process, okay? So you take your hands, right? And then you compress back and gently squish. Now, everybody's going to think it's going to come shooting out. That's not going to happen, okay? Breast milk is precious. And so you're going to see these little glistens, and they're going to take the little glistens. And if you feel like you need to do something, you can take the little glistens, and you can, with a clean finger, obviously, and put it in baby's mouth, okay? Sometimes that alone will help get baby to perk up and then find the breast, okay? So self-latching with skin to skin in the breast crawl is really the easiest way to latch baby in the beginning, because you're new, baby's new, and so it's really encouraging for the birth parent to have baby latch on. This is new. This is practice and patience. The first day of life, it's really important to remember that baby feels as good as you do. And hour to hour, it changes. What we're looking for is a few good feeds, okay? A lot of practice latching, and 1 pee and 1 poop, okay? Day 2, we're looking for 2 pee, 2 poop. Day 3, 3 pee, 3 poop. It matches the day you're on, okay? Until you get to day 4, right? Colostrum, remember the first milk, it's really important. It's thick, it's sticky. It's not going to come shooting out of your breast. It's designed that way because it coats the GI tract. It also acts as a laxative to pass the first poop, which is called meconium. And you're going to know what I mean, because after you change your baby's diaper, you're going to see this black tarry poop, and that is meconium, and it's really hard to get off. And colostrum's a wonderful natural laxative to help pass it. And your baby's poop is going to change as baby gets more and more milk intake. So the more milk your baby gets, the poop's going to turn from black tar to a little green to full-on funky breast milk yellow. And we're looking by day 5 to not have any more black poop. And you should notice that color change from black tarry poop to green to yellow, no more black by day 5, okay? Hunger cues. I see this so much. I can't reinforce. Anytime you even remotely think baby looks like they're hunger cueing. So what does that mean? Babies know they need to feed, they start rousing, right? Okay? Anything to do with the mouth, feed the baby, offer the breast. If baby hasn't fed in 2 or 3 hours since the start of the last feeding, wake baby up, change the diaper, right? That's a really great way to rouse baby to feed. Place baby skin to skin, go back to hand expressing, offer drops. If you want to, you can even hand express into a spoon. A spoon is 5 ml. You can fill that spoon up, put it to baby's bottom lip, and then they'll lap it up like a little puppy. Sometimes that little bit of milk is all they need to really kind of perk them up, place them skin to skin, allow them to do the breast crawl. There's all different types of positions, and I'm going to link to some videos, deep latching. Please, babies are not supposed to nipple feed, okay? They're not supposed to just shove them on there and then suck the nipple like a straw. It really is nipple to nose. This is the mouth, nipple to nose. Mouth opens, breast is folded down in, and that nipple is all the way back by that soft palate, okay? Notice when the nipple is back by the soft palate, it's not touching anything. If you're in pain and you're just shoving the baby on the nipple and they're gnawing on your nipple, and you're gonna see a compression line, and you're gonna be in a lot of pain while feeding, post-feeding, and it's not great for a milk transfer because we really weren't transferring any and we were in pain, so it's good for nobody, okay? Nipple to nose, let baby's mouth open wide, fold down, and then let them nurse accordingly, okay? There's a few different positions that I'm gonna review here. So we reviewed the easiest, which is self-latching. Just lean back, let nature take its course, okay? The other one is if we, and I'm just gonna tuck this real quick, is if we have baby belly to belly, okay? Nipple to nose. Notice my hand placement. It's behind the head. It's not here, it's not there, it's all the way. I'm literally just stabilizing the back of the head. I'm letting baby open up. So I'm gonna give you this great visual, okay? So this is what I mean, nipple to nose. You literally I tell everybody, lay your hand like this. Take your thumb. See how I do that and the nipple rises? Nipple to nose, wait for the mouth to open, and fold it down in, okay? So, nipple to nose, wait for that mouth to open wide, fold it down in. That is the motion. So whether you're in a cross cradle, going across your body, or you're in a football hold, it's all the same, okay? And there's any variation. There's not one position. The best position is where mom or birth parent is comfortable and baby's actively nursing. If baby is on there doing like light butterfly sucking and you're not really feeling pulling and tugging, well, you begin to question how much milk your baby's transferring. You should feel some butterfly sucking followed by pulling and tugging. And I always like to show everybody by taking your arm. So light little finger touch and then pulling and tugging. Good latching is pulling and tugging, actively removing the milk. Babies will naturally pause, and that's okay. If baby falls asleep and you want to encourage more intake, do a breast compression. Gently compress the breast, okay? So if baby falls asleep, massage, bother them, talk to them, remove clothing, and then hand express, okay? These are all ways to really encourage increased intake. I don't care what your nipples look like, okay? Whether you have innies, outies, they're long, they're round, talk to the lactation consultant, okay? All boobs are good boobs, and sometimes you just need to know and work with a IBCLC to really understand how to make yours work for you and to make the most of them, okay? There's not one type of boob that is better than another, and people say all kinds of things about anatomy that really is misplaced, okay? So your boobs are perfect, and we're going to work with them, and we're going to make them work for you, and there's a lot we can do, and there's a lot of options, and I think that's really important for everybody to know that, and that working with an international board certified lactation consultant is your best bet, because that's what we specialize in. We specialize in helping families breastfeed their babies and or provide human milk to their babies, whether that be through breastfeeding, at breast, and or pumping, whatever that looks like for you, okay? This video is designed for those that are going to breast. Maybe in the near future I'll do one for exclusive pumpers, and I'll talk about pumps. That's a whole other can of worms, but I would encourage you to contact your insurance now to make sure that you know how to obtain your breast pump and get one as soon as possible. It's really important just to have one on hand, okay? You know how to hand express now, so that's great. We have a safety net, but it's also really helpful to already have the breast pump and understand how to use it, so that way, in a pinch, if we need it, we don't have that learning curve as well, okay? So to recap, breast crawl, let the baby self-latch. If you need to, hand express, okay? When baby is even remotely looking like they want to feed, offer the breast of baby. You're not going to over breastfeed your baby, okay? It's not going to happen. And if we want to make lots of milk, which we do, you need to remember the more breast stimulation tells the hormones in your brain, believe it or not, your pituitary gland, what to do, and the more milk removed, more milk made. Your body's smart. The more you use it, i.e. more breast stimulation, more milk removal, the more milk you'll make. We really want to make oodles and oodles of milk. So if we put the work in and offer the breast on every single hunger cue, offer one, burp and bother, rouse, offer the other one, okay, you're maximizing your baby's intake. Now you're going to say, well, what if baby just nursed off one? Well, I tell everybody in the first few days of life, we're greedy. We want to maximize our body's ability to make milk, and we want a really well-fed baby. So we're going to offer. Offer means we're not going to force, but we're going to offer both breasts. So you offer with one, right? Baby feeds, we got good pulling and tugging. Well-fed baby, what does it look like? Well, they melt off the breast, and or you feel it considerably softer. Baby looks milk drunk, okay? You may have heard those little swallows. Those swallows sound like little sounds, okay? Watch your baby. There's so much to learn, and they're going to evolve over you. Every 24 hours, you're going to see this change. It's very dynamic, all the changes that are taking place. And it's a lot to retain because you're sleep deprived. So keep track. Write down all the pee and poop. Write down all the feeds. Do your best to kind of quantify, was it a good feed? What did I experience? Did baby take one breast or two breasts? Offer breastfeed one, burp and bother, offer the second. Now you're going to say, well, do I have to burp every single time? Burping with breastfeeding is more about rousing the baby to offer the second breast, and it's a really easy way to do that. And so I always tell everybody, yes, just take baby, breastfeed baby, baby's done, burp and bother, okay? Maybe they will, maybe they won't, but rouse them. Once they start rousing and start cueing, offer the other breast. Allow them to feed as long as they want on the second breast. There are no time feedings, okay? Baby's allowed to be on the breast as long as they're being active, and it's mutually agreeable that baby's there with parent, and that you can expect baby day 2 to wake up. So day 1, you're gonna have to rouse them. They're pretty sleepy. Day 2, they call it second nighting. They wake, they rouse, they're crying. It's actually normal. They were taken from their womb to this outside world, and they're trying to make sense of it through you, the birth parent. And they need to suck to soothe, and it's actually really important for them to stimulate, to drive up your milk supply, and to remove the milk so you keep making more and have a well-fed baby that keeps passing all of the important pee and poo diapers. Increased milk intake for the baby is going to reduce a lot of the typical newborn problems. So that's why I always encourage you, even if you remotely think that baby maybe you want to feed the baby. The more milk in baby, the more milk you make, and the reduced risk of all kinds of different medical things that we have to deal with that are common, but to the family, they feel really large and overwhelming. Talk to your lactation consultant. When they're in your room, they're seeing so many patients. That's your prize time. Make sure you have questions, and then ask for the help that you need, and ask for a referral list. Know who to go to after you are discharged or the midwife leaves. Know experienced help. IBCLC is the gold standard for lactation. If you're not sure who's near you, I will link to all kinds of good resources to help you find them. There's a lot of wonderful private practice lactation consultants that are here invested in having you have the breastfeeding experience that you're looking for, okay? To recap again, we're looking for pee and poop count. That is really important. Quality of feeds. Did you feel pulling and tugging? Did baby look milk drunk, or was baby breast sleeping? I.e. they were kind of on there but just doing a little bit of butterfly sucking. How do your breasts feel? Your breast should have changes, right? So typical milk volume increase. You hear people say milk coming in. Well, the truth is we knew this, that we already had milk, right? So now the volume's just increasing because you've done all your work. That milk volume increase, which is really going to happen the first day 3 to day 5, no later than day 7. You should really have that milk volume increase between day 3 and 5, no later than day 7. Now, it can vary. And obviously, if you didn't have this milk volume increase on day 5, and they're telling you that you have a greater than 8 to 10% weight loss, then we may have to be pumping and or doing more hand expression to supplement. And somebody should have laid eyes on the baby, i.e. an IBCLC, to get that extra intake as our body catches up to having increased milk volume. So we're going to then pay attention to our breasts. So as our milk volume increases, now it's about not just feeding baby, but it's also making sure that we don't end up with very full and engorged breasts. So breasts kind of right now are kind of soft like your earlobe. Full breasts are kind of like the tip of your nose. You avoid your breast feeling as hard as a rock, like your forehead. That is full on engorgement. And if you feed frequently, every single hunger cue, and allow baby to feed off one or mother offer the second, you're going to have more milk removed, and you're going to be less likely to end up with full-on engorgement. Full-on engorgement, okay, tells your body you don't need as much milk. Slow down the milk-making train. Remember, stimulation and milk removal drive supply. Well, if you have full breasts, your body says, doesn't need as much milk. Reduce, downregulate the supply. Well, that's not what we want to do. We want to maximize our supply through baby, the best tool to do it, because the baby should be removing the amount of milk they need, and then we have a balance. So if we nurse baby frequently, every hunger cue, no less than every 2 or 3 hours, from the start of the last feed, you're ending up with softer breasts and you're avoiding engorgement. And that milk volume increase between day 3-5 is really the milk volume that's going to get your baby back to birth weight. All babies lose weight, but they really shouldn't be losing more than like 8 to 10% without eyes being laid on the family and active IBCLC care. Okay? If you feel like this is a lot of information, you're right, it is. You've never done this before. And that's why it's really helpful to have one-on-one consults. So I wish you the very best, and there's all kinds of different ever-changing information about breastfeeding your baby during COVID-19. I'll link to the updated information, but I really encourage you to speak up for yourself, and knowing that the parents are the primary caretakers for baby, and you'll be leaving the hospital with baby, and that skin to skin is very important to the process and to the stress levels of both the birth parent and the baby themselves. Take care, and thank you.